Hey everybody, happy snow day. This is our OB class today, and I hope you're all somewhere cozy and warm and watching the snow fall. So this is our last class before you have your test next week. And so I'm going to screen share and go to my copy of the PowerPoint for today so you can follow along at home. Okay, so here we go. All right. So you should at this time be able to see the slides for the neonatal period. And let me, um, okay, I think I'll probably just work from this view actually. So the neonatal period is obviously the last step in our OB class. So just to recap, um, we've had the antepartum, we've had intrapartum, we've had postpartum, and now we're going to talk a little bit about the neonate today. And that is going to take you right up until pediatrics. So you are going to learn about the newborn period, and we will not be going beyond that today. Okay, so there's obviously a lot of change happening at this point. And as far as our focus in nursing care, we are going to mostly be supporting, again, a normal process as the newborn undergoes a lot of different physiological changes and adaptation. The nurse is going to be responsible for assessing various physiological changes and also at the same time recognizing potential risks and helping educate the family so they know what to look for as well. Okay, so there are a few things that as nurses we are going to be focused on for the newborn. So the newborn is born, it is placed in the best of circumstances on mom for early skin to skin contact. And so the things that the newborn needs to be able to do right away are maintain their body heat, breathe, um, keeping the risk of infection low, and feeding. And then again, helping parents learn to care for their baby. So let's take this system by system. Respiration is probably the most important new thing that the newborn learns to do. And this is the most immediate thing that must occur after birth. The baby is born, and remember that as soon as it comes out of the womb, all of those cardiac shunts close, and the baby must use its lungs for the first time, and that needs to work right away. So what we see in the real world is that 10% of newborns are going to need some help at birth. So that may be as basic as some suctioning, some free flow O2, and then 1% are actually going to need a full-blown resuscitation. And some of that we can anticipate, and some of it we can't. So the key is that we have to be ready at every birth to intervene if we see issues for the newborn. We have talked about that there are a couple of factors that can really impede this transition or make us anticipate that we're going to need to help the newborn. One is if the baby is preterm and has decreased surfactant levels. So remember from our earlier lectures that preterm babies are before 37 weeks and that surfactant does not really begin to be produced in any quantity until 28 weeks. So you definitely have some scenarios where babies who are preterm are going to be lacking in that. And then if a baby has had intrauterine distress, if we've seen late decelerations, a prolonged deceleration, a bradycardia, we can assume that the baby has already been experiencing some hypoxemia and acidosis in the womb. And that can lead to constriction of the pulmonary arteries. And once we've got an acidotic baby, even after it's born, it will not always initiate respirations successfully. So what do we see? When a baby is born with respiratory distress, there are some obvious things that we would notice. A baby who is cyanotic, especially central cyanosis, is a real sign of obviously lack of oxygenation. As an aside, lots of babies have acrocyanosis. That is, centrally they are pink, but they have bluish hands and feet. And that is a very common finding, actually. We'll talk about that when we get to APGAR scores, actually. But otherwise, other signs would be a full-on apnea or a tachypnea. Um, our normal rate, you'll see at the bottom of the slide, is between 30 and 60 breaths per minute. So a rate lower than 30 or above 60 are abnormal. Babies will use accessory muscles to aid in breathing. So you might see retractions, flaring of the nostrils, grunting. I've talked with some of you all in clinicals. A newborn that's grunting doesn't sound like a child or an adult grunting. It sounds like the baby is cooing, making little like whoo, whoo types of vocalizations. And that is sometimes mistaken by parents as cooing, but newborns actually don't coo. Cooing is a later in the first year of life kind of development that babies develop around 3 to 6 months of age. They don't do that as newborns. And then hypotonia. So a baby who's got low tone, a baby whose limbs are flaccid, who is not moving or pulling their extremities into the body, a baby who's just limp. All of those are possible signs of respiratory distress. To move on from that, the circulatory system is something that's very important for the newborn for supporting respiratory function. So recall that we change the baby's circulatory system as soon as the baby is born and that umbilical cord is clamped. The blood will stop shunting away from the lungs and immediately perfuse the lungs. And if that doesn't happen in a smooth fashion, you can get cardiac compromise with incomplete shunt closure. And you all will talk about that some in peds. The normal heart rate in the newborn is very similar to that of a fetus. So 100 to 110 to 160. It can vary with crying and sleep. We always measure heart rate for a full minute, and actually we always measure respirations for a full minute. We know that with respiratory, with the baby's breathing pattern, the baby can have an irregular pattern, but they shouldn't be in distress. So 30 to 60 breaths a minute, no distress, but irregular is considered normal. Similarly, heart rate should be around, like I said, 100 to 110 to 160 beats per minute. And that may vary a little bit as the baby is crying or moving. So we do want to count an apical pulse for a full minute. Okay, so for newborn resuscitation, we have A, B, C, and D. And so this is a little acronym to help you remember. So if we're resuscitating a newborn or we're assessing a newborn to see if it's going to need resuscitation, we look at, do we have a clear airway? Is the baby breathing? Is circulation, happening? And finally, do we need to give medication? So let me talk a little bit about the drug options for a newborn resuscitation. And those are on the slide. If mom has recently gotten narcotics and we've got a respiratory depression that we suspect is due maybe to mom having received fentanyl within the last hour, and then the birth just happened sooner than anticipated, the nurse can give Narcan or naloxone as part of that resuscitation. If we suspect a prolonged intrauterine acidosis, like with the late D cells, and so we suspect metabolic acidosis, the baby can be given sodium bicarb. And if we have issues with circulatory and we need to increase our heart rate, say we've got a bradycardic baby, you can give epinephrine, and you can give that either via the ET tube, or you can give that intravenously. And I usually talk about this in class. Some of you may or may not be aware what is the fastest way to get intravenous access on a newborn at delivery. Starting an IV on a newborn is tricky and it takes time. So if we needed to give medications very rapidly and we needed an IV access, the fastest way to do that is actually via the umbilical vein, to actually place an umbilical catheter. After the cord is cut, the umbilical vein remains patent for a short period of time, usually for up to the first 24 hours of age. And so while it doesn't work as a long-term IV site for a newborn, it can be an emergency site right at the beginning. Okay, so this slide illustrates the all-important APGAR scores. And so you may need to know how to do an APGAR score. This is a nursing assessment and a nursing responsibility to give the APGAR. Um, at delivery, APGARs are assigned at 1 minute of age and at 5 minutes of age. And it's important that the nurse does not assign an APGAR until the baby is a full 60 seconds old, because a lot of newer nurses get really caught up in the moment, and as soon as the baby is out, they want to assign that first APGAR. But we actually do need to wait 60 seconds to let that baby have a little bit of transitional time before we start assessing. So APGAR, Virginia APGAR was an OB, and so this is named for her. And she recognized a need to do for a standardized, quick assessment of any newborn to determine and assess for need to resuscitate or provide support. So we have 5 criteria here listed on the left. So that's heart rate, respiratory effort, muscle tone, reflex irritability, and color. And then each of those is assigned a score, either a 0, a 1, or a 2. And these are the criteria here. And these are things that can be assessed almost always by just looking at the baby or briefly listening with a stethoscope. It is almost always a score that can be obtained with the baby on the mom, maintaining skin to skin. So we don't need to like take the baby away from mom. So again, so let me to go through these topic by topic. So heart rate, if it's over 100, they get a 2. If it's bradycardic, they get a 1. And if it's absent, they get a 0. So obviously you hope that all babies have at least a 1 for heart rate. Respiratory effort. So if baby is vigorously crying, they get a 2. If we've got a bradycardic, if we've got a slow respiratory rate, it's they're going to get a 1, and if they're not breathing at all, they get a 0. Muscle tone is an interesting one because it's very, very noticeable when a baby is born and is just limp with no movement at all, and that gets them a 0. If they're moving and flexing their extremities a little bit, they get a 1. If they're actively moving, they get 2. Reflex irritability, basically how irritated is the baby by their surroundings? They're coming out of a warm, dark environment into a bright, cold environment. And so a vigorous newborn is going to demonstrate their irritability with that scenario, usually by crying. And so if they're not responding to their environment at all, that gives them a lower score on that criteria. And then color. Color is one that often babies lose 1 point for because at 1 minute of age, having the baby completely pink right up through the fingertips is kind of unusual. Usually that takes until at least 5 minutes, sometimes a little beyond. Getting a 1 for color refers to the body being centrally pink, but then the extremities still having a bluish color to it. That's called acrocyanosis, and that is actually not abnormal. The hands and the feet in the newborn have very tiny capillaries, and they take a little longer than the central part of the body to become fully perfused with oxygenated blood. Excuse me. So all this to say, a baby who is born and at 1 minute of age is moving, crying, flexed in towards, with their extremities, and has decent color, even with some acrocyanosis, is almost always going to get an 8 or a 9 in terms of their APGAR score. I know I'm spending a lot of time explaining this slide, but if a baby gets a 7 or better on their 1 minute APGAR, that usually does not indicate a need for anything beyond watchful observation of their transitional process. A baby who's scoring below a 7 almost always is going to need some sort of support, whether that's O2, suctioning, stimulation. Babies who score below a 7, or I think a 7 or lower on their 5 minute APGAR score, also get assigned a 10 minute APGAR score. So if you're continuing to kind of get a borderline score at 5 minutes, you do go ahead and score again at 10 minutes. Okay, so we're going to move on to that, but this is a helpful slide to know. All right, now let's talk about some of the complications that are common to all newborns. All babies are vulnerable to cold stress. This is heat loss, and that can lead to lower body temperature. And what happens in newborns is newborns cannot shiver to raise their body temperature. So when a baby gets cold, they don't have an easy way to raise their temperature. And so what they do is they increase their metabolic rate, they increase their respiratory rate, and that increases their oxygen consumption. And when they do that, their heart rate speeds up. And because they're doing that, they drop their blood sugar because they're increasing their metabolic rate. And what can happen is the baby can sort of spiral down very quickly into respiratory distress and deoxygenation just because they were cold. So we really try to prevent this. So to kind of recap, so the baby is going to respond to cold by increasing their metabolic rate. They can't shiver, but they may at least initially try to move more or pull their extremities into their body. They will have peripheral vascular constriction, which can lead to a prolonged acrocyanosis, but they should still be centrally pink. And they metabolize brown fat. Now, brown fat is a special substance newborns have, and it lets them engage in non-shivering thermogenesis. That's creation of heat without shivering. Brown fat is a highly dense adipose tissue. They don't make more of it, so they're born with it as a compensation mechanism to help them maintain their body heat in the first few days of age until they get older. And if they burn through that too quickly, that's where they can really get into trouble with respiratory stuff. Because if they burn through all of their brown fat, they will drop their blood sugar, and they, again, will raise their metabolic rate to try to compensate, and they won't be able to. So the best thing we can do for our newborns is to maintain a neutral thermal environment for them. And this is where a neutral thermal environment is where they can maintain their body temperature with minimal metabolic changes or oxygen consumption beyond the norm. So just to kind of go way back to like earth science for you, it's important to realize how we maintain our body temperature and how we have heat exchange. This slide kind of summarizes that. Probably for the newborn, the most immediate loss of heat is evaporation. So when they come out of the womb and they're born and they're covered in amniotic fluid, if we don't dry that baby off quickly, they are losing a lot of body heat through evaporation as that fluid dries. So the best thing we can do for that newborn is dry them quickly. Convection, conduction, and radiation are all important factors as well. We try to keep newborns away from drafts. We try not to position their cribs near, right under ceiling fans that are turned on and things like that. So we try to maintain their environment so they don't have to work overly hard to maintain their body temperature. So that just to remind you all how you would prevent cold stress. So when the baby's first born, you dry the baby and then remove that wet linen and you put a hat on their head. We try very hard to keep the baby skin to skin with mom, especially right at the beginning. If mom is unable to provide skin to skin contact, we might use the radiant warmer, but the mother's body does a better job. After that first hour, we will want to swaddle the baby. And if we have a baby who's cold, if we have a baby that is below 97.7, and that's the key temperature, with their temperature, we want to place them naked under a radiant warmer. They look like French fry lights. And we also want to be checking vital signs and temperature and actually blood sugar for a baby who is cold. A baby who appears to be in early stage cold stress, we need to check their respiratory rate, their respiratory effort, and their blood sugar. And if their blood sugar is under 40, we need to treat that by usually feeding them with a little bit of sugar water or formula, even if they're breastfed, so that they're not getting hypoglycemic. And if 40 surprises you as a acceptable blood sugar for a newborn. You're not alone. We have very different standards for babies than we do for older children or adults. Okay, so the baby is born. What is the nurse doing initially? They are maintaining the baby's airway, which might be as simple as just stimulating the baby to cry and clear secretions from their mouth and nose on their own. We're going to keep them warm by drying them and putting a hat on them and keeping them on mom. We are going to get them banded quickly. Proper identification is really important. We actually, even when there's a need for a full resuscitation, we will not remove a newborn from the mother's room until the baby has a band on it. And then if we're going to do medications, these are the ones that we do early on. Now, I say if, because this is kind of standard practice, but parents, of course, are allowed to decline or delay these medications. So we don't want to just do them without explaining to the parents why and what we're doing. We are giving most of the time, a vitamin K injection in the vastus lateralis of the baby's thigh. Babies are born with a sterile gut, and they don't begin to synthesize vitamin K until they are older. And by older, I mean 7 or 8 days of age. So vitamin K, if you're not aware, is an important component in the normal clotting cascade. And so it's a small but potential risk for hemorrhagic disease of the newborn. So if a baby is born and does not receive a vitamin K injection, it does not mean that they're all going to bleed out, but it does mean that a very small number of babies will be at higher risk for bleeding disorders. And so that's the reason for that. And then the erythromycin ointment that's placed in the baby's eyes, the eye drops, that is a prevention for neonatal gonorrhea infection of the eyes. Now, do all of our mothers have gonorrhea? Of course not. So we're doing a lot of antibiotic eye ointment for probably a prevention of a very small number of infections, but it is a serious infection if it does occur, and it can actually lead to blindness. So it's something that if a parent does want to decline or delay, we just want to make sure they're fully informed about the purpose of these medications and what they're either consenting or declining. And then we do all of this while supporting bonding and early feeding. Okay, so here's a picture of the baby getting the erythromycin ointment. It's done from the inner to the outer canthus of the eye. It's pretty non-irritating, although it does look a lot like Vaseline, and it makes the newborn's eyes look goopy. So if the parent asks, what's that in their eyes, you can explain. This slide gives you a handy sort of reference for vital signs of the normal newborn. Reminders here of what our normal ranges for temperature. We almost always are taking the baby's temperature axillary. Usually babies only get a rectal temp done one time to determine anal patency. But so almost always we're going to be doing that axillary. Here's the heart rate range, respiratory rate. Blood pressure we don't take very often. If it's a normal, healthy newborn, they might only get it done one time, and that's it. Babies who end up in the NICU or critical care nursery are going to, of course, get vital signs checked more frequently and at different different intervals than the healthy newborn. Okay. This is a list of things that, as the nurse, should be red flags for you if you're doing an initial newborn assessment. So, of course, abnormal vital signs, signs of labored respiratory effort. Low tone, as I said, is always kind of concerning. Abnormal newborn size. This is a red flag simply because we know that much larger babies or much smaller babies have certain risks. And this should start now to kind of tie into what you know from the intrapartum and from antepartum. So we know that smaller babies, for example, may be more at risk to have low blood sugar and a low body temperature because they don't have as much subcutaneous fat. And because of that, they may be at more risk for respiratory problems. Similarly, a larger baby can be more at risk for certain birth injuries. They also can be more at risk for having trouble maintaining their own blood sugar because it's more likely that their mothers had diabetes. Um, and they can also, because of their risk for low blood sugar, be at risk for respiratory difficulties. So it all kind of ties together. Jitteriness may or may not be a warning sign, but it's something as a nurse to be aware of. A lot of babies have kind of jittery, jerky movements, but a baby who's really persistently jittery, that can be one of the signs of low blood sugar in the newborn. Okay, let's talk about another potential complication. Babies have sort of a underdeveloped hepatic system. Their liver is immature at delivery, and it's not that it doesn't work at all, but it is still still developing its function. So all babies are at risk to become jaundiced, and this happens when they have too much bilirubin collecting in their system, and the liver is slow to clear it. So bilirubin exists in two different forms. Indirect bilirubin is it's a fat soluble substance that happens when red blood cells are broken down. And when it's indirect, it's unconjugated, so it's hard to get out of the system. So in order for the baby to eliminate bilirubin, it has to be conjugated and then becomes direct bilirubin, and liver enzymes do that. And it becomes a water-soluble substance that they can excrete through their urine and their stool. So babies, newborns, get rid of the excess bilirubin in their system by pooping and peeing. So, and what encourages pooping and peeing is good feeding. So babies who have become jaundiced have hyperbilirubinemia. It's when they have kind of a backlog of unconjugated bilirubin that's not being cleared. And this can happen, again, just because they have immature livers. They are not yet peeing and pooping regularly when they're first born. And some babies have kind of a higher RBC count at birth. It's a result of their fetal hemoglobin that is going to be converting to neonatal hemoglobin, but it takes a while. And then some babies are at higher risk because they had more bruising at delivery, and they already have extra RBCs they have to break down and clear. Okay, so two types of jaundice. There's physiologic and there's pathologic, and we worry more about the pathologic, obviously. But 60% of newborns are going to get some degree of jaundice. It is going to resolve without any treatment. The keys with the physiologic jaundice is it appears usually after 24 hours of age, and it's going to go away by 7 days. It is kind of defined as you're never going to see the unconjugated serum bilirubin level being above 12 milligrams per deciliter. And it's actually going to be a little more common in breastfed babies. And that's because breast milk is a little slower to come in terms of volume. And so babies sometimes are a little slower to get going with their peeing and pooping pattern, voiding and stooling pattern, sorry. And so breastfed babies sometimes look a little pumpkiny or yellow, and that's kind of a normal finding. On the other hand, pathologic jaundice, it appears early, usually before 24 hours of age. The serum bili is going to be at or above 15 milligrams per deciliter. In its most severe form, if it's untreated, it can lead to a neurotoxic state called kernicterus. And this is where bilirubin has built up actually in the brain tissue, and this is irreversible. So it's rare, but it is why we are very vigilant about jaundice, because it causes permanent brain damage. So a couple more things to say about jaundice. The key to avoiding jaundice is for baby to eat early and often to avoid and stool normally. Babies can be exposed to natural light in the home, and that's helpful. Babies who get kind of high on their bilirubin or borderline on their bilirubin may need to spend a little bit of time actually under UVA lights, or UVB lights, sorry, which are called bili lights. And they can either be under like in an incubator with lights, or they can be wrapped in a bili blanket, which is a light blanket that has lights impregnated in it, and this helps because the bilirubin gets into their skin, and that's where it's visible as jaundice. It helps them actually break it down and clear it from their system. So natural light is a help for this. Um, and most newborns are tested for jaundice before they go home from the hospital around 24 hours of age. Okay, moving on to the metabolic system. As I've already mentioned, a baby who gets hypoglycemic is a baby whose blood glucose is below 40. And we know, hopefully now you can name some of the things that puts a baby at risk for low blood sugar or hypoglycemia. So when mom is diabetic, that puts a baby at risk because the baby has been in a very sweet environment, and then they're born and they no longer can maintain their own blood sugar to the same degree. So they kind of have a rapid dip. Also, we know that large for gestational age and small for gestational age babies are at higher risk for hypoglycemia. Similarly, babies who are overdue or preterm. Babies who get cold, who have hyperthermia or respiratory distress, or babies with infection. Babies who are septic have a higher metabolic rate trying to ward off the infection, and so they burn through their blood sugar reserves more quickly. So early signs and symptoms, as I've said already, jitteriness, low tone, breathing difficulties, and low body temperature. So early feeding is key. You want to feed these babies early and often. You want baby at the breast within an hour after birth if they're going to breastfeed. You want to, at the same time, reduce the demands on their metabolic system by keeping them in a neutral thermal environment. And you want to educate parents about this. Like, why do you want to feed your baby on demand? And why should you keep the baby warm? So this is a lot of anticipatory guidance and teaching in order to prevent a much more serious complication. Okay. The baby's GI system, so speaking of feeding, the baby is able to eat right after delivery as long as they're breastfeeding. As I've mentioned, I think in the postpartum lecture when we talked about breastfeeding, baby has a very tiny stomach capacity early on. It's about a teaspoon on the first day of life, and it only goes to about 3. Hey, I'm just checking. I think for a minute there, I kind of lost you guys, but I'm going to reshare my screen. Okay. There we go. Going back to this. All right, cool. So all babies lose a little bit of weight after birth, and that's because they're, again, coming out of a wet environment into a dry environment. So all babies lose some water weight through evaporation. It is important, though, that no baby lose more than 10% of their body weight. And so if babies are losing too much, that can put them at risk for dehydration and kind of point to some early signs of feeding difficulties. We watch out for signs of jaundice. We want babies eating well without signs of infection at their clamped cord, or if they had a circumcision, no signs of infection there. We want them voiding or stooling. And like I mentioned in the postpartum class about breastfeeding and really bottle feeding, we want a baby to have one wet diaper for every day of life up until about 7 days of age, and then ongoing from there. And usually at least one or more stools per day. And we also want to make sure that mom and dad are learning how to take care of their baby, that they're attentive. They don't have to know everything, but they have to be interested and attentive. And we want to do any required newborn screenings and parent education at the same time. At RMH, newborn screenings include things like hearing screening, cardiac screening. We do the PKU, which stands for fetal ketonuria, which is really, they call it the PKU, but it's the metabolic screening. It's done at 24 hours or greater of age, and it screens the newborn for a whole lot of kind of rare but easily detectable metabolic conditions. The reason that this one is really important is that almost all of these metabolic conditions, if they're caught early, can be managed and treated. If they are untreated, they can lead to irreversible damage. So, if you're talking to parents about like, are you going to do the vitamin K? Are you going to do this? Are you going to do that? I honestly, if parents are fully educated and wish to decline like the erythromycin eye drops, that does not give me a big headache. But the PKU is actually, or the metabolic screening, I think is a really important one for all parents to do because it is absolutely identifying preventable long-term permanent damage to the newborn. So that's kind of an important one that I think all parents should consider doing. All right, so now I'm going to move through a bunch of slides relatively quickly that talk about kind of components of the physical assessment of the newborn and what are normal variations that you might see. So some of you who are in clinical have already seen some of these in real life. All right, there are lots of different common skin variations in the newborn. Vernix is the white, cheesy, cold cream type substance that most newborns have on their skin when they're born. It is harmless. You can rub it in. You can wash it off, whatever you want to do. And we're going to go through some of these other ones here. Some of these are a little hard to see on the slides, but milia is little tiny white dots across the baby's nose on that center slide. That's completely normal. Erythema toxicum is here. This is that baby acne that lots of babies get. It's kind of a combination, again, of exposure of the skin to life out of the womb and also somewhat to mom's hormones. Mom and dad should not pick at this, should not squeeze it, should not put any antibiotics on it. It will clear on its own. So that's very important for parents not to try to treat that. Other things here, birthmarks, very common. This slide A here, the first one is a stork bite or a nevus or a nevis. That is very commonly seen. And then this slide to the far right is a baby with a Mongolian spot. So babies with darker complexions, so African American, Hispanic, Middle Eastern, often are born with sort of this bluish black discoloration over their buttocks, and it's very normal, very much expected. And most parents of those cultures are aware that this is a normal finding, but it's something that occasionally you do have to explain to parents what it is and that it's normal and that it goes away over time. It's not a sign of injury or anything else. Okay, there's the erythema toxicum slide. Nevus vasculosis, lots of babies have birthmarks, and this is, again, usually not a problem, but babies sometimes have these little, when they're more pronounced like this, they have their own blood flow. So again, it's just something that they'll be monitoring as the baby gets older. Kind of a rarer one, nevus flammeus. This is the port wine birthmark. Port wine staining. This is a permanent birthmark that it will be with the baby their whole life, and it can be, it's not harmful, but it can be disfiguring and look unusual. So it's something to educate parents about if they do have a child with some port wine birthmarks. Lots of babies have molding at delivery. So we've talked about this a little bit when we talked about intrapartum and how the baby fits through the birth canal. The plates of the newborn skull are designed to move and shift with birth. And so when the baby's born, you literally can often feel these plates sort of molding and overlapping each other. What this can result in, though, is a couple of different variations in head shape with the baby at birth. So this is two images here of two different ways a baby can have sort of a cone head at delivery. One is caput and one is cephalohematoma. So, caput, which is image A, is very common. Most babies born vaginally or babies where mom pushed for a long time, even if she had a C-section, will have sort of this caput, which is sometimes symmetric, or in image A, sometimes asymmetric. It is a collection of serosanguinous fluid, and it is between the scalp and the periosteum. It goes across suture lines, and it resolves usually within a week of age. So it does not increase any risks to the newborn. On the other hand, cephalohematoma, which is image B, is less common, but is more likely with a traumatic delivery, with a vacuum-assisted or forceps delivery, or prolonged pushing. And so what you have here is a collection of actual blood that is between the periosteum and the skull bone. And because it's under the periosteum, it does not cross suture lines. So instead of being kind of symmetric over the crown of the head, it can be very asymmetric, ending abruptly at the suture line. That can take quite a while to resolve. That can take up to 3 months to resolve. And it will resolve, but it does appear more obvious for a while. It also increases the baby's risk of jaundice because that's a pretty large amount of trapped blood that has to break down and be eliminated by the baby's liver. So that's something to be aware of. Here is an image of a baby with a cephalohematoma. This looks sort of like a classic vacuum-assisted delivery head. Not every baby with a vacuum has a cephalohematoma, but it's more common, as I said, with an instrumental vaginal birth. Okay, reflexes in the newborn, as some of you already know. Newborn reflexes are how we do a neuro assessment on a baby. Newborn reflexes are unique to the first 3 months of age, at which point they are slowly phasing away. And they are cute and fun, and you can show the parents as you are assessing them. And lots of babies will just demonstrate them very spontaneously, like sucking on things, rooting, which is turning the face towards, or turning the mouth towards something that touches the cheek. This baby right here in the picture is demonstrating their grasp reflex, palmar grasp. And in the lower image, we're demonstrating a Babinski reflex, which in the newborn is the flaring of the toes, which is completely opposite from what you see in a Babinski reflex in an adult, which they curl the toes, but a baby will flare the toes, which is how you get a good newborn footprint, incidentally. This is the Moro or startle reflex. When babies are startled, or they hear a loud noise, or like their crib gets bumped, they will fling their arms out and look classically startled, just like this baby. This is a tonic neck reflex. This is a hard one to elicit, but it's sometimes called the fencing reflex, because if you turn the baby's head to the side, they will assume a fencing posture with the head and the arms. Your textbook, by the way, has some good images of all of the different newborn reflexes. And you can look at it there. You'll also experience these in clinical with your newborns. Okay. Now, we have talked some about breastfeeding, and we have talked through many of the benefits for mom and baby if a baby is going to breastfeed. At the same time, I've also mentioned in class that not every mom who wants to breastfeed her baby is able to breastfeed her baby. So we want to have a lot of compassion and care for people in their choice making. For women who do choose to breastfeed, it's really important that moms are responsive to infant cues, that when the baby is alert and interested in feeding, that mom knows to get that baby to the breast. Coaching and support for mothers is really important. Meeting with lactation consultants is often an option in a lot of hospitals. Um, and we, as nurses, really want to make sure that moms have an idea about what is normal for breastfeeding. The breastfed babies are going to feed 8 to 12 times in 24 hours. That they will void and stool regularly as a sign that they're getting enough, that the baby will gain weight. Um, so these are all anticipatory things. Um, for bottle or formula fed babies, we do all need to realize that the majority of babies will get a little formula at some point. Even breastfed babies often have some circumstance where they end up getting formula at some point. So it's really important that everybody understands something about how to prepare formula, how to handle it. It's really important, for example, that if you're mixing powdered formula, that you teach parents the right proportions and that not to water it down or try to stretch it out. um, we want to provide parents with community resources. Breastfeeding and bottle feeding parents often of lower income will qualify for the WIC program, which provides a lot of resources um, for mothers and babies. And we also want to make sure they get breast pumps if they're going to be needing to pump their milk, and that they understand how to store breast milk. Breast milk can be stored in the refrigerator for a short period of time. It can also be stored in the freezer for a really long period of time. But you should never, never, never rewarm breast milk in the microwave because it can heat really irregularly. So you want to thaw or defrost or warm breast milk in a special heater or in like a bowl of warm water. So there's things like that that are very important to be able to help parents with. And as I said in the postpartum class, any nurse who works with in a maternal child really needs to know at least some of their community resources, because that's key when you're doing teaching, to be able to tell parents where to go or who to get in touch with after they leave the hospital. All right. We've talked about this a little bit. There's some common concerns of the newborn I'm just going to touch on briefly here. Transient tachypnea of the newborn is probably the only one we really haven't talked about. Hypothermia, hypoglycemia, and jaundice are on other slides. Transient tachypnea of the newborn, TTNB, is a kind of what it sounds like. It is a transient elevation in respiratory rate that happens for some babies. Probably the most common scenario is babies born by C-section. Babies who were not in any distress, but who did not get squeezed through the vaginal canal at delivery. And so they are born with lungs that are a little wetter, a little more congested, and they may have a slightly elevated respiratory rate while they are clearing that fluid and transitioning to extrauterine life. The only thing that can sometimes happen, often babies with transient tachypnea transition just fine with a little bit of extra O2 and sometimes time in a warmer, so they maintain a neutral thermal environment. But babies who have transient tachypnea who aren't supported in that way, again, can get into that spiral of they've increased their metabolic rate, they get low on their blood sugar, they burn through their metabolic resources, and they end up in respiratory distress as a result. So if we support newborns, they do fine, but if that's missed or we don't, they can actually develop more serious complications. And we've already talked about hypothermia, hypoglycemia, and jaundice. Okay, a few complications that I want to address here. And again, this should all be starting to sort of come together for you based on some of our other class lectures. Neonatal sepsis, the most common scenario is a mom who is positive for group beta strep. Remember that sepsis with strep B is rare, but it can occur, and we try to prevent that by making sure that mom gets antibiotic therapy in labor at least 4 hours prior to birth, so that that can be basically delivered to the baby intrauterинely via the placenta. Babies whose moms were group beta strep positive do need to be monitored closely for the first 24 to 48 hours. And it's easiest to do that, of course, in the hospital. So often we do not want to discharge a positive GBS couplet until 48 hours of age, especially if the treatment was not given because maybe the birth was really fast or something. Um, a septic baby can deteriorate relatively fast. And if it actually progresses to meningitis, there is a 50% mortality. So it's serious. The most common signs of sepsis in the newborn are actually hypothermia. Babies don't tend to run a fever. They tend to get cold, and they tend to get respiratory distress. So those are the things that are most commonly associated with the septic newborn. So let's talk a little bit about just some special scenarios and variations in birth weight and gestational age. And again, this should start to really sound familiar to you guys. So I'm hoping it sounds repetitive. That would be good. Quick reminder of what is preterm, term, and postterm. And a quick reminder of birth weight variation. So we have small for gestational age, which is at or below the 10th percentile. Large for gestational age is at or above the 90th percentile. And then AGA, which is appropriate for gestational age. So that's that middle 80% of newborns. Okay. And a quick reminder of, we also have some variations based on birth weight. So these might be actually full-term babies, but they might be very restricted in their birth weight for various reasons. Smoking is a very common reason here, but there can be other things, uteroplacental insufficiency, preeclampsia, hypertension. We often see growth-restricted babies. Okay, with all of that said, how do we know when a baby is born if their gestational age meets their developmental age? Now, we have a pretty good idea of this usually, especially if we have good dates. If the pregnancy was dated appropriately, that's always very helpful. But say that you have a small for gestational age baby that's born, and you're thinking to yourself as the nurse, I wonder if they got those dates right. I wonder if this is really a full-term SGA baby or if this is an appropriate gestational age baby who's preterm. Well, we use a developmental screening tool. The nurse completes this usually during their first assessment of the newborn. Sometimes this is referred to as the Ballard gestational aging tool because it was developed by somebody named Ballard. And what this tool has is a set of criteria. So the top, you've literally got a stick figure and you can demonstrate different levels of flexibility and tone based on gestational aging. So it's kind of hard to see on the slide, but suffice to say that preterm babies are much more flaccid in their tone and therefore much more flexible. So you can actually put a preterm baby through lots of different positions because they're just super flexible. As a baby gets older, they lose some of their flexibility, they develop more tone, and because of that, they resist super hyper flexible movements. So the nurse literally will put the baby through these different postures and circle the little stick figure that corresponds to the baby in front of them. So yes, there is some subjectivity here, but it's still the nurse who gets to make this call. So the top is neuromuscular criteria. The bottom is developmental criteria. And so some examples here, like soles of the feet. Preterm babies have very smooth feet with few creases. Full-term and post-term babies have increasingly creased feet. So that's one thing. They look at the soles of the feet. Another thing here is like genitalia. Preterm babies, little boys, don't always have the foreskin covering the glands of the penis, whereas a full-term baby does have a foreskin that covers the penis. Same with little girls. The labia majora do not cover the labia minora in preterm babies, but by the time they're full term, they do. So these are just also developmental criteria. So the nurse will circle all those, and then based on their score, that actually corresponds to weeks gestation. And they can see if that corresponds to what they know about that baby's due date and all that. So that's how we formally get a diagnosis of LGA, SGA, or appropriate for gestational age, or AGA. Okay. So this, again, is a visual to give you some characteristics of a preterm or premature baby. So here's, you can see like they're holding up the sole of the foot, and in the bottom, there's some genitalia differences. Um, Upper right, the baby's ears, like in a full term baby, the cartilage in the ears has really a quick recoil. But in preterm babies, the ears are still kind of floppy and they don't recoil as quickly. And then you can actually, the middle pictures just shows, like with the legs, like how very flexible a preterm baby's joints are. Like the baby's legs are like completely out to the side, whereas in a full term baby, the baby is more flexed in towards the middle. Okay. And this I just include because kangaroo care is really cool. When you have a preterm baby that's having to have support for their body temperature or their growth or their respiratory rate, kangaroo care, skin to skin contact with a parent or loved one has been shown to be very, very beneficial to the newborn. So I just want to put a plug in for that here. Okay. A few things about post-term babies. Now, we don't see that as often because we tend to induce these babies, but a baby who is gestated beyond 42 weeks also has some sort of notable characteristics. This is where you'd see very dry, cracked skin, heavily creased feet. Sometimes the umbilical cord looks thin and like it's sort of starting to reach the end of its lifespan. Meconium on the skin because it's more likely the baby will move its bowels in utero as it stays in there longer. And overly long fingernails, actually, because the baby's nails grow the whole time. Um, we've talked about some of these things. Whenever you are doing your admission on a mom in labor and delivery, or you're taking care of a new mother and baby, it's good to know something about the mom's history because the mother's history is the baby's history. And knowing these things are things that place a baby at risk for variations in either their birth weight or their gestational age. So a lot of these you've seen already. When you've got a small for gestational age newborn and you're assessing it, other than some of the characteristics we've already talked about, it's important to know that the head will often look disproportionately large compared to the rest of the body. And that's because an SGA baby often has been sort of not received as much nutrition and oxygenation in the womb. So the resources it has received have been sort of prioritized to the development of the neurological system and actually the cardiac system too. So you'll have a well-developed head and brain with a very wasted appearance in the extremities. And of course, reduced sub-Q fat, less muscle tone, especially over the buttocks and the cheeks. And again, kind of a scrawny looking umbilical cord. Again, if this is feeling repetitive, it should now because it should all be tying together. Small for gestational age babies, remember, they are more likely to have trouble tolerating labor. So they're more likely to be born with perinatal asphyxia or being acidotic. They're going to have a harder time maintaining their body temperature and they're keeping their blood sugar up. And they're more likely to be distressed in labor. And so to have aspirated meconium with delivery, which can cause a cascade of events where they are more likely to need resuscitation and have trouble with respiration at birth. Similarly, remember that we expect LGA babies from moms who had diabetes or moms who just have big babies, LGA babies. When moms go overdue, if mom herself is obese or has a higher BMI, and yeah, keep in mind genetics. If you've got two parents who are 6 foot and 6'6", they are probably not having a 6-pound baby. We know, again, that babies who are born large for gestational age have some higher risk for birth injuries. They're going to have harder time keeping their blood sugar up, so they need to be fed often. And then jaundice secondary to, just their larger size and more red blood cells to break down, and also, again, tying into possibility of birth injury. Remember that as nurses, that we are always going to have the possibility to encounter a newborn with either anticipated or unanticipated conditions at birth. Some are acquired. So these are things that happen maybe during the delivery or acutely because of like hypertension in the mother, preeclampsia, fetal distress, and that's things that maybe have developed acutely. And then there's congenital things that we are going to discover or know to anticipate at birth, and usually it's due to some kind of again teratogen or a genetic or an unexpected. A good example here is like a club foot, something that can be corrected, but the parents are still going to need to be aware of at delivery. And this is a huge list. There's a whole lot of them, just different things that can happen. And some of these become then things that you all will see in infants when you do your peds rotation. So they all kind of tie in together. And that is the end of the newborn lecture. I'm going to go back to my screen here and stop screen sharing. So I hope that made sense. I probably went through it faster than I do in class because we actually did not need to stop for discussion. So after watching this and listening to this, if you have questions, please email them to me. And good luck on the test next week. It's going to be, I'll probably send out an email about that. So hope that helped, and I'll talk to you guys soon. Take care.